Welcome to Creative Diagnostics channel. This video we are going to talk about the influenza virus infection. Influenza is a highly contagious viral infection that usually causes seasonal outbreaks in winter. Depending on the climate and geographical location, influenza can cause seasonal epidemics or sporadic outbreaks in winter or other seasons. The virus can affect multiple organs and typically presents as an acute febrile illness with varying degrees of systemic and respiratory symptoms. Common symptoms include fever, chills, headache, fatigue, red eyes, sore throat, dry cough, and runny nose. In high-risk individuals or groups, influenza can lead to severe or even life-threatening complications. The influenza virus evolves rapidly and frequently undergoes antigenic variation. Influenza viruses belong to the orthomyxoviridae family and are RNA viruses. They are enveloped viruses with segmented, single-stranded negative-sense RNA genomes that encode two surface glycoproteins, hemagglutinin, HA, and neuraminidase, NA. HA attaches to receptors on the host cell surface and initiates viral entry, while NA aids in viral replication and helps release new viruses from the host cell. Influenza viruses are classified into four types: A, B, C, and D. Type A influenza is the most common during flu season, causing mild to severe illness in both humans and animals. Type B influenza is highly contagious and can sometimes cause serious illness, but usually results in localized outbreaks. Type A viruses are further subtyped based on variations in their HA and NA antigens. Influenza can occur as pandemics, epidemics, outbreaks, or isolated sporadic cases. In temperate regions of the northern and southern hemispheres, seasonal influenza epidemics usually happen in winter, while in tropical areas, outbreaks can occur throughout the year. The epidemiological patterns of influenza reflect changes in the virus's antigenic properties, which lead to the emergence of new strains, affecting both transmissibility and population susceptibility. Antigenic shift occurs when there are rapid and significant changes in the surface glycoproteins, especially HA, of influenza A viruses, usually due to genetic transfer from animal strains to human strains. Although rare, antigenic shift can lead to pandemics and epidemics. Antigenic drift refers to minor changes in the HA or NA proteins, which are more common and typically associated with localized outbreaks. For influenza B, only antigenic drift in HA has been observed. Birds are an important reservoir for influenza viruses. The H5, H7, and H9 subtypes have all caused avian influenza outbreaks in humans. Among them, H5N1 has a mortality rate as high as 50%, resulting in many hospitalizations and deaths. Therefore, these diseases pose a significant future threat to human health and require close attention. The influenza virus is commonly transmitted from person to person through sneezing and coughing. The main routes of transmission include 1. Direct contact with infected individuals, 2. Contact with contaminated objects, and 3. Inhalation of virus-laden aerosols. Respiratory transmission can occur during coughing, sneezing, speaking, singing, and even normal breathing, as these activities can release aerosols containing the virus. After infection, viral shedding begins about 24 to 48 hours before symptoms appear. To control the spread of the virus, it is essential to cover the nose and mouth when coughing or sneezing and to wash hands with soap, alcohol-based cleaners, or solutions to prevent transmission. The incubation period for influenza is typically 18 to 72 hours, though it varies between individuals. Symptoms appear suddenly and commonly include high fever, severe headache, extreme fatigue, muscle and joint pain, along with eye discomfort and respiratory symptoms. While most systemic symptoms last about a week, fatigue and coughing may persist for several weeks. Children experience similar symptoms as adults but may also have nausea, abdominal pain, ear infections, or vomiting. The most serious complication is pneumonia. Primary viral pneumonia causes high fever, dry cough, breathing difficulties, and bluish skin discoloration. Secondary bacterial pneumonia, often caused by Staphylococcus aureus or Streptococcus pneumoniae, usually develops around 3 days after flu symptoms begin and is marked by productive cough, elevated white blood cell count, and lung abnormalities visible on imaging scans. Other potential complications include heart problems, muscle inflammation, and neurological disorders. It's important to note that elderly individuals, young children, and people with chronic medical conditions are at higher risk of developing severe complications from influenza. Influenza diagnosis is typically based on clinical presentation, laboratory testing, epidemiological data, and symptom assessment. Cough and fever are the most predictive clinical symptoms of influenza infection. During outbreaks, most cases can be diagnosed clinically due to the high accuracy of clinical diagnosis. Laboratory testing methods include rapid influenza diagnostic tests, PCR, nucleic acid amplification tests, viral culture. Among these, reverse transcription PCR, RT-PCR, is the preferred method due to its high sensitivity, greater than 80%, and specificity, providing results within 80 minutes while detecting influenza subtypes and antiviral resistance. Immunoassays can detect influenza antigens in respiratory samples within 30 minutes, offering simplicity and high specificity but significantly lower sensitivity compared to molecular tests. Their detection rate depends on disease progression, and due to high false negative rates, they are not suitable as the sole basis for clinical decisions. Viral culture allows strain typing using endotracheal aspirates, nasopharyngeal secretions, or sputum, but dried samples may render the virus inactive. Traditional tissue cell culture takes about 10 days, while shell vial culture requires around 3 days. Neither meets the need for immediate clinical decision-making. Other routine lab tests, e.g., elevated white blood cell count suggesting bacterial co-infection, only serve as supplementary indicators. Influenza vaccination is one of the most effective public health measures for infection prevention. Its protective effect depends on vaccination coverage and the match between vaccine strains and circulating viruses in a given season. Studies show influenza vaccines can provide up to 60% effectiveness against both type A and B viruses. Currently available vaccines include inactivated influenza vaccine, IIV, live attenuated influenza vaccine, LAIV, and recombinant influenza vaccine. For the 2019 to 2020 season, most trivalent vaccines contained 2 type A strains and 1 type B strain, while quadrivalent vaccines included an additional type B strain. In the Northern Hemisphere, early autumn vaccination is recommended for optimal protection before the flu season, October-May. Unvaccinated individuals can still benefit from later vaccination. Pregnant women should receive IIV regardless of previous vaccination during pregnancy, as it protects both mothers and infants for the first 6 months after birth. Influenza vaccination is recommended for everyone aged 6 months and older. Adjuvant trivalent vaccine, ATIV, and non-adjuvant vaccines are approved for those over 65. Non-adjuvant quadrivalent vaccines are for ages 6 months plus, while recombinant quadrivalent vaccine is recommended for adults 18 plus. Cell-based quadrivalent vaccine is approved for ages 4 plus, and quadrivalent LAIV4 is for healthy individuals aged 2 to 49 with 90% effectiveness in children, but contraindicated in pregnancy and immunocompromised individuals. For uncomplicated influenza and low-risk cases, symptomatic and supportive treatment is primarily recommended. Adequate hydration is essential to compensate for fluid loss caused by fever. NSAIDs such as aspirin, naproxen, diclofenac sodium, and ibuprofen can help relieve fever, headache, and muscle pain. Controlling body temperature helps prevent chills, myalgia, and tachycardia. Currently, for antiviral drugs are approved for influenza treatment and prevention: oseltamivir, zanamivir, peramivir, baloxavir marboxil. The first 3 are neuraminidase inhibitors, NAIs, which work by blocking viral neuraminidase activity to prevent virus release. Oseltamivir, an oral medication, is indicated for uncomplicated acute influenza within 48 hours of symptom onset in patients aged greater than or equal to 2 weeks and for post-exposure prophylaxis in those greater than or equal to 1 year. Zanamivir, an inhaled formulation, is used for acute treatment in patients greater than or equal to 7 years and for prophylaxis in those greater than or equal to 5 years. It can shorten illness duration by about 2 days but is contraindicated in severe milk protein allergy and may cause side effects like bronchospasm. Peramivir, administered intravenously, is approved for adults greater than or equal to 18 years as a single-dose treatment. Common side effects include diarrhea, but it is not yet approved for pediatric use or prophylaxis. Baloxavir marboxil is a cap-dependent endonuclease inhibitor that works by interfering with viral RNA transcription to suppress viral replication. This medication is approved for treating acute uncomplicated influenza with a single oral dose within 48 hours of symptom onset in patients aged 12 years and older, though it is not yet authorized for preventive use. Reported side effects include headache, nausea, and diarrhea. Adamantane drugs, such as amantadine and rimantadine, target the M2 ion channel protein of influenza viruses. However, due to high resistance rates, they are no longer recommended for influenza prevention or treatment. Antiviral therapy is primarily recommended for hospitalized patients with severe influenza and high-risk individuals susceptible to serious complications, as it can effectively reduce fever duration and complication rates. Oseltamivir is suitable for severe influenza cases in non-hospitalized patients and community cases. Antiviral treatment shows significant clinical benefits for high-risk groups including children under 4 years old, adults over 65, immunocompromised individuals, pregnant women, and others. Notably, broadly neutralizing antibodies against viruses such as dengue, hepatitis C virus, respiratory syncytial virus, and influenza have been documented in research. In particular, antibodies targeting the sialic acid binding site and stem region of influenza HA can neutralize the virus by blocking its binding to host cell receptors. Extensive studies suggest these antibodies targeting conserved epitopes of influenza viruses may become a novel therapeutic approach. In summary, influenza is a preventable contagious respiratory disease. It can cause severe complications and even death in healthy individuals of all ages. Difficulty distinguishing influenza from other viral or bacterial respiratory infections within the effective treatment window for antivirals often leads to delayed antiviral therapy. Influenza vaccines remain the most effective means of preventing influenza and its complications. However, for older adults, who bear the highest burden of influenza and have the lowest vaccine effectiveness against severe outcomes, more effective interventions beyond antivirals are still needed. Thank you for watching. If you want to gain more knowledge, subscribe to the Creative Diagnostics channel. We are dedicated to help you succeed and advance your research progress. Visit our website for more information.